No, 30 seconds.
30 seconds, okay?
Me voy a mute.
Okay.
Good
We
luck.
are live.
¿Estamos en vivo?
Yes.
Ok, hola a todos, ¿cómo están?
Espérame un segundo, Nelson, para hacer pasar a la gente.
Ah, dale.
Para hacer pasar a la gente, porque sí, vamos avanzando. No importa que salgamos en vivo un ratito antes de empezar. Cuando tú quieras, Nelson.
Ya, vamos. Hola a todos, colegas, ¿cómo están? Bienvenidos a esta tercera jornada. Quisiera darle la más cordial bienvenida a todos ustedes para esta tercera jornada online de la Sociedad Chilena de Kinesiología del Dolor. Muchas gracias por estar con nosotros en este evento, el cual tenemos la suerte de contar con una gran expositora de lujo. En esta tercera jornada de este nuevo ciclo, ustedes saben que tenemos varios exponentes internacionales y por lo tanto estamos muy contentos de poder compartir con ustedes toda esta información con la comunidad y además con nuestros socios de nuestra sociedad de kinesiología del dolor. Primero, darles algunas ideas generales de la charla. Acuérdense que pueden dejar sus preguntas en el formulario de YouTube. Si están en Zoom, pueden también realizarlas y un colega, miembro de la directiva, va a estar recogiendo. Y cuando termine Bronnie su presentación, vamos a elegir las mejores preguntas para poder compartir un poco más. Así que hoy día contamos con una expositora de lujo. Ella es Bronnie Lennox, que nos acompaña desde Nueva Zelanda y hablará sobre razonamiento clínico en el paciente con dolor persistente. Darle las gracias desde ya a la doctora Bronnie Lennox por estar con nosotros. Muchísimas gracias. Ella es terapeuta ocupacional, tiene una maestría en psicología y un doctorado en medicina de rehabilitación. La pasión de Bronnie es ayudar a las personas que experimentan problemas de salud crónico a alcanzar su máximo potencial en la vida. Ha trabajado en los campos del manejo del dolor crónico durante 20 años, ayudando a personas a desarrollar habilidades de autocontrol mediante una combinación de terapia cognitiva, también terapia cognitiva conductual, terapia de aceptación y compromiso y otras terapias físicas. Bronnie, además, es profesora de la Universidad de Otago en Christchurch, Nueva Zelanda, y nos encanta que nos esté acompañando hoy día en esta jornada. Así que, por favor, siéntanse cómodos y disfruten de esta tremenda presentación que tenemos. Así que bienvenida una vez más a Bronnie y le cedo la palabra para que pueda comenzar con esta tercera jornada.
Solo una cosa antes, decirles que de la interpretación, si quieres, Nelson, ¿puedes decirlo?
Sí, eso voy a decir ahora. Quería mostrar que
dale,
para la gente que está en Zoom, pueden ahí elegir en la parte inferior, va a aparecer ese símbolo del mundo, donde pueden presionar en interpretación y va a aparecer la opción de español, en donde pueden escucharlo con nuestra traductora de forma simultánea. Para los amigos y colegas que nos están siguiendo en YouTube, van a escucharlo en el idioma original de Bronnie, que va a estar en inglés. Así que muchísimas gracias una vez más. Ahí está la doctora Bronnie Lennox. Recuerden que más o menos hasta las 21 horas vamos a estar y después vamos a tener un pequeño ciclo de preguntas para finalmente recordarles nuevamente que pueden ser socios y miembros de nuestra sociedad. Así que muchísimas gracias.
So should I share screen, should I?
Yes, please.
Yeah, please.
Here we go. Thank you so much for the invitation and the very warm welcome. It's an absolute pleasure to be able to join with you today from chilly Christchurch in New Zealand to talk about my favourite topic, clinical reasoning, pain assessment, and helping people with pain learn to live well, even though they have this thing to live with. I'm going to say a few words in Māori first of all. Kia ora koutou. That is, kia ora is good health. Katoa is everyone. And that's a Māori greeting, and we live in a bicultural nation, so we honour our tangata whenua, who are people of the land. That's our Māori partners in this land. I'm tangata tiriti, which means I live in New Zealand by right of our Treaty of Waitangi, which was between the UK Crown and the people who lived in New Zealand before we arrived. And so I'm very privileged to be able to meet, to live in New Zealand, and also to live in this bicultural nation that we have. So without further ado, let's have a look at pain assessment and case formulation. And so I'm going to talk about three things. One is about pain assessment and this clinical reasoning process. We'll talk briefly about diagnosis versus formulation and what the differences might be, and then we'll have a deeper look at case formulation. And I'll take you through it, I hope, in a way that will make sense. So I'd like you to meet Angelina. Angelina is 23. And she has been having brief episodes of neck pain over the past 2 years. She thinks it's been related to falling off a horse. And although she didn't seek treatment at the time 2 years ago, she's been very careful and limited her riding since then. She works in a responsible job, managing a retail store, and she's been achieving good sales figures. But recently, her neck pain has been bothering her more than usual, and she's been having trouble getting comfortable at night. In the morning, it's been hard for her to turn her head to reverse her car. And she's noticed that putting her arms up to do her hair is quite uncomfortable, and she's expected to be well groomed in her job. At night, when she gets home, she's not comfortable sitting in her usual chair in the lounge, and she's even stopped going to the gym because she feels that it aggravates her neck pain. Her partner is not very sympathetic and has told her to just keep going to the gym because you can't go wrong getting strong, he says. But Angela feels he's being a bit simplistic and he's minimising her distress. She's particularly worried about an upcoming conference where she's going to need to drive for 2 hours to get to the venue, sit for the whole day, and then drive 2 hours home again. So she's probably somebody a bit like someone you've seen before. What do we do for someone like her? And my suggestion is that we need to think beyond the fact that she has neck pain. That's important. But the questions we might need to ask are these. Why is Angelina seeking help right now? Why did she wait 2 years? What might be maintaining her current problem with her neck? What does she want from seeing us, from her encounter? What would you offer her? And how might this help to reduce her distress and her disability? Just take a moment to think about that and see what you come up with. The point is that we often, as health professionals, make assumptions about why people see us. Why do they want to seek some help? We also assume that they know what they want and can state it clearly. We forget that the people that we see in treatment are not, they don't represent the full range of people who are experiencing pain. And we also forget that seeking treatment is influenced by these other factors. For example, social factors. Was it her partner that suggested Angelina come and seek help? Or was he saying, don't bother? Culture. Is it normal for someone to have pain and to not be bothered by it? What do we say about neck pain in our cultures? Most cultures would say that having neck pain is a bad thing. We should be able to fix it. What about the economic situation? Can she afford to seek help? Or does she just have to put up with it? And what about motivation? Why now? We also often assume that if we reduce the pain, that this will also reduce illness. I'm going to talk about illness shortly. And that if we treat the disease, whatever disease it might be, that will also treat the illness. So disease is about the person, the parts of the disease processes inside the person. And we assume that that disease process is going to be the same in Angelina, in me, and in anybody else. Illness, on the other hand, is the experience of what I think is going on, my experience of being sore, of the limitations that this poses for me. And Angelina's reasons for seeking help are probably more related to her illness, what she thinks is going on, the impact that it's having on her, than on the disease process, particularly given that it's a pain problem. The longer that we're in practice as clinicians, the more we get to use or rely on mental heuristics. So these are rules of thumb that we develop about why somebody's seeing us, what they remind us of, and what we should do. And this can be both good and not so good. The good parts about heuristics are that it makes it faster for us to make a decision about what we're seeing and what we should do. The not so good parts about it are that by jumping to conclusions about what we're seeing and what we should do, we group things together to make it easier to remember. And this means the special, unique factors or the unique things about this person in front of us can get forgotten. And so there are differences between making a diagnosis, which is about identifying the disease process that's involved, and developing a case formulation, which is trying to explain this person's illness experience. And our mental models, the ways that we think about health, disability, illness, and disease, make an enormous difference to the kinds of pieces of information that we prioritise, both the things that we look for in our assessment and how we weigh up the things that we look for. And so when we're looking at assessment, we need to ask ourselves, why? Why am I assessing? What am I assessing for? And what goes in to our assessment and what doesn't? In physical therapy in particular, we look at the subjective, things that the person tells us, and then we go on to the objective. And in the objective, we narrow down our focus until we identify the disease, the diagnosis. And what this can mean in practice is that these clinical questions can get forgotten. And the questions are, and I think these are the key questions that we need to ask ourselves when we are meeting somebody for the first time in a clinic, is why is this person presenting in this way at this time? Why now? Why are they looking the way they're looking? Why did they seek help from me and not from someone else? And why now and not earlier? The second question we have is, what's maintaining this person's current predicament? What's keeping Angelina stuck? And the third question is, what can be done to reduce her disability and her distress? Because very often with pain, we can't address the disease. For example, if she's young and she's fallen off a horse, she might have some osteoarthritis developing in her neck. And we can't change that osteoarthritis. So we can't address the disease. We don't know if the osteoarthritis is the thing that's causing her pain. We might assume that. And it might not be. And if we can't address the disease process, the osteoarthritis, we might be able to change her pain, but we might miss out on the very things that are bothering her. So let me talk a little bit about the difference between disease and illness. The place that we work is, as rehabilitation professionals, is slightly different from medicine. In medicine, diagnosis is really important and prognosis is really important. And that matters to the person as well. But where we work is in this space, this rehabilitation space. And we have life. And this is what the person wants. What they want is this part coming back. And yes, they want to know about the diagnosis and the prognosis, but the work that really goes in for them as a person is in this rehabilitation phase. That's where our energies need to go. And the problem with this phase is that it's not nearly as clear cut as making a diagnosis or a prognosis. It's messy. And it's messy because a person's life is going to be different for Angelina, for me, and for anybody else. So where we're trying to help is in this messy space, which means we can't really simplify it. Because if we try to simplify it, we lose what matters to this person, or we risk losing what matters to this person. So the disease part is this diagnosis. This is the tissue problem. The illness part is the life. This is what I want to go back to. I'm going to take you through a story. So we have Angelina, and we have all this information from Angelina about what is going on in her life. There's an awful lot of it, and this is only from the subjective. I'm not taking the objective part. Let's just look at the subjective. And the thing is, when we look at this, it's messy. There's a lot of information. And so what we want to do is try and structure this in a way to help us make sense of it. These are the mental models that we hold in our heads as we try to make sense of it. So one way we might do is to look at the psychosocial yellow flags. These are the psychosocial factors that can get in the way of somebody recovering nicely or cleanly. So let's make that information that I presented you and let's break it down. We have attitudes and beliefs. We have behaviours, things that the person does. And then we have some diagnostic and doctor kind of material. I haven't included in here that she might have osteoarthritis in her neck, but not much change on imaging. And so we could say that her pain is nociplastic, possibly, and that there are no surgical or procedural options. And then we have her emotional response. She's scared. She finds it hard to think. She's angry that they didn't work out what was wrong earlier. She's not very confident that she can manage this by herself successfully. And as well as that, she has her family thinking that she shouldn't move, but her partner who thinks that she needs to just get stronger. And we have, in her case, this is used from another case, she could have been not working. And that can add another layer of problem on top of it. And yet what we often see in our treatment is none of this. We see exercise to reduce pain. And all of this important stuff might not get brought into our clinical reasoning. So I want to bring you back to Angelina. And here are her main problems. The bit that we usually focus on is this part. I hurt all the time. And that's the part that we focus on. But what we don't focus on so much is the part that says, sorry, what's wrong with me? My sleep is really bad. I'm feeling down in the dumps. And I'm not getting out to see my friends. So now that we know this, let's go back to that information and see how we can rearrange it so that we can make some sense of it. Here's one way. We've got these parts. We could call these biomedical or the biological part. I'm going to break this into the biopsychosocial model because it's a nice heuristic. It's a way of arranging things. We can put this part as the psychological part, so her feelings, her thoughts, her ideas about what might be going on. And we can have this part that's about the social behavioural part, the things that other people see and the things that other people say to her. And we put the past opioid use up in the corner. So that's one way that we can arrange this information. Now we need to work out from her problems that she identifies, which ones of these problems or this information that we have might lead us to help explain the problems that she's describing. So her problems are sleep, low mood, and she's not seeing her mates and she'd like to. So we have the same information. Now let's draw some arrows. We've got the reason, what are the reasons or the things that might be contributing to her poor sleep? Well, it's that aching, shooting, burning, tingling. She can't get comfortable. She's also angry and mulling it over in her mind as she tries to get off to sleep. She can't think straight because she's so worried and angry about what's been happening. And she's worried that if she takes medications now, this might mask the real problem. And that's playing around in her mind. And as a result, she's using medications very erratically. And she's resting as often as she can. She believes that if she rests, she'll be able to sleep better because that helps to reduce her pain. But we could see that probably resting doesn't help. It actually increases her problem with sleep. So these are some of the areas that they can give us some ideas about what we could do in our treatment approach for this woman. Yes, we can treat her pain, but unless we treat these other things, we won't address the thing that she's most concerned about. We could do this for another problem. Let's think about seeing her mates. She's worried because medications mask the real problems, so she's not using the medications, which makes her grumpy. And she's worried about her pain. And she's worried that her mates aren't happy with her because she doesn't come to things anymore. She believes that her pain means that she's got ongoing damage in her neck. And that means she can't think straight and she doesn't want to be around people, even though she really wants to. She doesn't like to be around other people because she's so grumpy. And she's angry, and all she talks about is that they didn't work out what was wrong. And she's resting a lot so that she doesn't go out at night because she's tired. And she's had to rest because she thinks that's the best way to handle her neck pain. And of course, she's using medication every now and then, and that gets in the way of the drinking games that she really likes to play. As well as that, she's got this stress response that's occurring, and she's embarrassed about that when she's with her friends. So if we want to help Angelina spend more time with her friends and manage her sleep, then we might need to look at some of these other factors in our overall approach to helping her. The interesting thing is that we don't have to be psychologists or doctors or occupational therapists to deal with this. We collect this information anyway. At the moment, we just put that to one side and we don't bring it in to understand why is this person presenting in this way at this time and what's maintaining the problem. And we're not relating this necessarily to the actual problems that she wants help for. Instead, we're jumping on to this idea of it's all about getting rid of her pain. So whatever way you synthesize your information, for us in a biopsychosocial practice, and there are lots of different ways that we can organize all of this information, but by taking some time to put the information out there and then arrange it into some sort of order, a formulation can help slow us down. Because if we keep using our well-practiced approaches to working out what's wrong, jumping to conclusions and relying on our memory, we can get caught up in these cognitive biases. Because we jump to conclusions, we think this person looks a bit like the last person we saw, or we might relate all the information that we're seeing to the latest journal article that we wrote or that we read. So we want to be able to slow our thinking down when we're working with somebody. It also helps us to organise this information within some sorts of structure so that we can use it. Because if we follow the subjective, objective diagnosis process, what we're missing out on is using all that wonderful subjective information that helps unpack why this person's presenting to us today in this way. It also helps us generate some alternative hypotheses about what might be going on. It would be easy to think that Angelina's seeing us because she has got a sore neck. That's what she seems to be seeing. But what we might forget is that she's coming to see us because she's not sleeping very well. And she's worried about what that might mean for her long term. And especially when she's thinking about driving for 2 hours to sit for a day at a conference and then drive home. And we need to think about some alternative explanations other than, oh, she's sore. It must be her neck osteoarthritis. We need to think beyond that into, I wonder why she's so worried about driving. I wonder why she's not sleeping. I wonder why she's not seeing people. And this in turn helps individualize our treatments so that we are working to what this person places most value on. In this case, I chose sleep and spending time with friends. So what I will do for her might be very different from somebody else who might prioritize getting back to sport and playing with their children. This helps us make sure that the goals that we are working towards are what this person values most, and the process, the treatment strategies that we use can be tailored to fit for this person. And this also, using this kind of approach, allows us to think across our professional boundaries, because we can tend to think sleep must belong to the psychologists. Worries about things must belong to the psychologists. And physical movements, being able to turn her head so she can reverse her car, belongs to us. But if we think a little bit more broadly, we know that physical therapy in particular can be really good for helping people with sleep. We know that if people can move more comfortably, they'll move more. And that will stop her resting as much. And that will help with her nighttime sleep. So we can think more broadly instead of just within this is my scope of practice. Identifying these problems doesn't mean that we have to be the person who deals with it, because this person might not see that those problems relate to some other profession. They've come to see us. So it offers us a chance to be creative in what we address and how we address it, and to bring in other professions to help us out. It supports this interprofessional collaboration. And I wanted to introduce you to this spaghetti diagram, because this is a program or an approach that Michael Nicholas and Steve Linton, who are both psychologists, introduce. And they use this in a paper, not this reference that I've listed here, but one that I've listed in my in the reference list at the end of this presentation. I've used that, they presented that in psychologically informed physiotherapy. So although I've presented this, my approach across the board, I'm not alone in saying that this way of thinking about problems and working back to a whole range of different things that might inform how this person's presenting. This is something that other clinicians have done, and it's okay within physical therapy as well. Just to reassure you. I just want to shift gears for a moment and talk about the difference between a diagnosis and a formulation. So Engel, who we know about because of the biopsychosocial model, was instrumental in helping us understand the distinction between disease and illness. He's not the only one that has written about this, but when he did, he was talking about the journey that people come through before they seek help. In his writings, he talks about the way that diagnosis clusters groups of symptoms and signs together. In other words, it reduces the variability. It says you are all the same because you've got these things in common. And it's doing so, diagnosis does this so that we can assume that there are some underlying mechanisms that are the same for everybody who presents in this way. So diagnosis is a really important skill. We use it when we communicate between one another. So when I say that somebody has fibromyalgia, you know, and I know, we're talking about somebody who has widespread pain, and we can't find a diagnosable cause for it. We know that people with fibromyalgia are likely to have really poor sleep, not a lot of energy, and they'll get sore really quickly when we change what they do. But what a diagnosis doesn't do is give an explanation for why this person is coming to see us today. And that is actually more meaningful, because people come with this diagnosis, but they come for help with their illness and disability. The sleep problems. I'm worried about what's going on. Yes, I'm sore, but what does that mean for my future? So diagnosis is really useful for us to talk between ourselves, and perhaps for some research, but it's not quite so useful when we're sitting in front of this person who's chosen to see us. So I've been advocating for quite some time that we should use a formulation, because these help us generate a series of hypotheses. For example, I showed you in the diagram that this person's sleep, Angelina's sleep, is possibly the result of a whole lot of those pieces of information. We don't know which ones really are directly related to her sleep problem, but we've got some clues based on what she's describing, and also based on our knowledge of research, of the things that we know can influence poor sleep. And what this allows us to do is create this individualized clinical theory that we can then test out. And that allows us to tailor our treatment to this person and what they want. And it privileges, it elevates this individual sitting in front of me. And I think that's important, because it allows Engel's model of this is a whole person that we have in front of us to be implemented in daily practice. I'm just going to flick past this next page because we've gone past it. So what we are trying to look for in, especially in pain, is a clinical reasoning process that goes beyond this category. Oh, you have osteoarthritis, you have a tendon problem, you have nociplastic pain, into here is a person with all of the things that matter to them in their lifestyle, the body, their mind and thinking, and the environment in relation to them as a person inside a system. And that is messy and complicated. We can't turn this person into an algorithm that says step 1 do this, step 2 do that, step 3 do this, because people are unique. Now, there has been some thinking about this approach in physiotherapy as well. And I'm going to show you two, some of which I think you may know both of these. The first one here is from Matt Lowe, and he's looking at this idea of tendencies, if you like. He talks about vectors. Here we have this person with positive factors, or factors that are leading one way and factors that are leading the other way. So we could have chronic stress up here. We could have fear of movement in here. We could have sleep. We could have anxiety. We'd have beliefs, mood and depression, social support, negative, and so on. And what he's saying is that in front of the person, we could draw a line and we could draw these vectors, so these directions, and say, in terms of Angelina, chronic stress is pretty high. So we'd put an arrow saying this is closer to the left-hand side. Where this T is the tipping point. This is reaching a critical point. If the arrow reaches over that T, then this person is starting to go into a negative state, a negative health state. This helps to explain why is this person asking for help today in this way. And what we do with all of these little arrows is we start to draw an arrow showing the directions of whether these are supportive, protective factors, or they're things that are vulnerabilities. And when we look at the total number, and we look at the direction of those arrows, we can say in front of the person, it looks like chronic stress, not feeling like you're confident at moving, your rotten sleep, your anxiety, and so on, they all add up to this direction in which your life is traveling. And this is reaching over the threshold or the tipping point to say things just aren't working out well. The reference for this, by the way, is in the reference list. I think it's a lovely way of pen and paper in front of a person, being able to look at what does this person bring, how can we show them why we're not looking at some things, but we are looking at others. And it helps us bring the person on board to understanding why it might be good to explain something about pain mechanisms, why we might talk about stress management, why sleep is important, not only because sleep is Angelina's priority, but also because we know that sleep interferes with recovery and it predisposes to chronic pain. So we can use this way of organising this information. I think it's a lovely way. On the right-hand side is the musculoskeletal clinical translation framework from Curtin University. So Peter O'Sullivan and colleagues looking at all the different factors and arranging them so that as we collect our information, we can put the information into these categories on one page in front of us. And we can see that for some people, the individual problems that they view, these are much more problematic than perhaps red flags. They don't have any red flags. We can see that there are some diagnosis. So for Angelina, we could see that she might have a little bit of osteoarthritis in her neck, but generally we could call it a non-specific neck pain. She's got a sore neck, that's all. And where she's at for her pain is she's had it for a long time, so it's in this bucket, it's ongoing. We know that if pain's been going on for a long time, then it's probably become more complicated. It's become associated to lots more things in this person's life. And it's had more effect on aspects of this person's life. And that makes it much more challenging to work. We can have a look at the pain features. In her case, we could say it's nociplastic. And that means that we know that there are some things we do for this kind of pain that we wouldn't do for nociceptive pain. As physios, you'll look much more at mechanical or non-mechanical types of problems, and the sensitization is something that we probably all do. This helps us weight that information that we've collected in especially in our subjective part of our examination or our assessment. We can arrange this in order and place relevance and use that when we're starting to work with a person for our treatment. We've got our psychosocial factors, which are things like, what does she think is going on? What's happening to her ability to concentrate? How is she feeling in herself? What's happening with her anger? How much is that getting in the way of her ability to get on and recover? And what's happening around her in terms of what does her partner say she should do, or her workplace say she should do. They've placed work considerations under different flags. I'm old, so I use the yellow flags as a generic, broad category. The yellow flags, by the way, were developed in Christchurch by somebody that I worked with very, very much Dr. Nick Kendall, and we started to look at this idea of factors that get in the way of recovering, that are very similar to those red flags that we must attend to and deal with very quickly. We thought that these yellow flags were the same kind of thing, but they were, and they needed to be dealt with just as actively and early. So that's a little bit of history for you. Looking at lifestyle factors, these are things like eating, her overall habits. Does she have a normal routine? What's she doing in terms of her weight? Is she a smoker? Does she use alcohol? In Angelina's case, she's used opioids in the past. What are the whole person considerations? Does she have other health problems? Does she have a mental health problem as well? Does she have some genetic factors that are important? And we have some, what she's actually doing, her actions, the kinds of things that she does. We can put all of these factors into our big picture when we come to our clinical decision making. This helps to break down the kinds of things that we have to think about and organise them into a structure. So then we can start to make some decisions about what we do next. For those that are not occupational therapists or are not physio, this is occupational therapy models. We've been using this kind of approach to bringing all of these multiple factors together for a long time inside occupational therapy. The person and environment and occupational performance or doing part is one model that we use, where we're looking at things like physiology, things like cognition, spirit, what's meaningful to this person, things that are about neurobehavioral control, that controls sensory inputs, balance, coordination, as well as psychology. These are all the person factors, inside the person factors. And then we have all of these external factors that we can draw on. Who's around the person? What sort of social and economic systems support them? What are the culture and values of this person in their particular neighbourhood and particular relationships? What's around in terms of the environment and the natural environment? And these intersect to create the things that the person wants to be able to do, these bits in here. For another model, this is called the Kawa model, and occupational therapists use this. It was developed in Japan, and it looks at the flow of life from moment to moment to moment. What's important for this person in this moment? The riverbanks, that's a picture of a river. So the river flow is our life flow. The riverbanks are the things, the environments that the person lives in. The rocks are obstacles and challenges that this person faces. The driftwood are influencing factors that can come and go. And the spaces are the opportunities we have to create some room. I'm going to go through this very quickly, but this is another way of thinking about breaking down how we might help somebody. I'm going to do it very quickly, but so don't be too tied up in the what I'm looking at. This is Tim Sharp's cognitive behavioural model of pain. And I like it because it gives us some information to begin, again, to break things down. So we have the person's experience of pain, and we look as clinicians at the possible mechanisms, the quality, the location, the intensity, the factors that increase it, the factors that reduce it. But we also need to worry about or be aware of this person's judgment about this pain. And we go back here, the things that they've had in the past, the experiences they've had in the past. So Angelina didn't have pain until she fell off the horse 2 years ago. So for her, this is really weird. Don't understand it. And in her culture, she comes from a culture, like most of us do, that we shouldn't have to put up with pain. We should be able to get rid of it. And then we have her emotional response. She's frustrated by this pain. She's angry and irritated and also feeling a bit demoralized. She's got a stress reaction to experiencing pain because she's so frustrated by it, because she's worried about it. It's not about having a psychopathological problem. This is not a mental illness. This is a normal person who's frustrated with experiencing her pain. And then we have what she does about it. In her case, this is from another case, but she could be limping. She could be guarding her neck. She may not be moving. If all we address is the movement, we're forgetting all of the rest of this, including the fact that she's monitoring what's going on in her neck every time she does something. As well as that, she's probably had other people tell her things. For example, she might have been told when she first did it, put some ice on it, take some medications. And that feeds into her understanding of what's going on. As health professionals, we have a profound influence on the judgments that people have about the seriousness of their problem and what's going on. And the final influence is these environmental contingencies. So this is other people, her workplace, her partner. So what do we do with this to turn this into a treatment? Well, watch me do this. So when we have the sensory characteristics, this can suggest the mechanisms, the kinds of pain modulation techniques we can use. If we leave it there, we're missing out on some really important things. In other words, all of this stuff that hasn't been addressed. So we need to have a look at her appraisals. What does she think is going on? And this is where we can use our conversations. What is this thing called pain? What is your diagnosis, the label for what you have? We can use cognitive functional therapy or cognitive therapy or acceptance and commitment therapy to help this person judge her experience differently. We're going to need to take notice of her emotions, because if she's frustrated or she's starting to get depressed or she's really anxious, that's going to influence her readiness to do the things that we want to do with her, which are generally about getting her to move again. She won't move if she thinks that her neck is going to break. So we need to talk about cognitive therapy, talking, acceptance and commitment therapy. We might want to give her some information about pain and setting some goals. When she's very, very aware of what's going on and monitoring her pain, her painful neck, then we might want to help her, again, talk about what is this pain mechanism that you might be experiencing. Let's understand pain. But we might also want to introduce some attention management, helping her become mindful, noticing the areas that aren't sore just as much as the areas that are sore. With her movements, this is where generally physical therapists and occupational therapists would intervene. We want to get people moving. And so this is natural for us. Again, if we forget these other things that I've covered, we're missing out on a whole lot of stuff that we can actually do for somebody. So we might use movement therapies. We might do graded exposure. We could even use biofeedback so she can help to recognize she has some control. And we can help with her family. We might want to talk to her partner about maybe being unsympathetic and saying there's nothing wrong with getting strong isn't the most useful thing for her at the moment. If we're helping her with her workplace, we might want to talk to her employer about the fact she needs a little bit of space to do things slightly differently for now. With community attitudes, I think we have a job to do. We don't do this very well at the moment because our communities just believe what they believe. But as we interact on social media, I think we can help to shift community attitudes. And that's part of the why we're doing this on YouTube, which is awesome. and why I'm on Facebook as well. Physiological responses, we can help that person with some self-regulation, to learn how to manage and to be with and to be comfortable with experiencing these responses without necessarily doing something about them. But we could also use some hypnosis or some other treatments. We don't have to do that. We could pass that off to somebody else, make a referral to someone in our network. That means we might need to develop some relationships with other clinicians. When it comes to her past experience, the things that she's been aware of, we might need to take note of what went through her mind before, her idea of who she was before she fell off her horse. And we might need to talk a little bit about some of these experiences that she's had. Was she really frightened? And take that into account, use that as part of our awareness when we're trying to help her start doing some new movements. And then we need to look at ourselves as health professionals. We need to be really careful about what we say, how we say it, avoiding these unhelpful, nocivic thoughts about, oh, your neck is grinding away, you've got degeneration, or you need to be very careful about how you move because you could end up in a wheelchair. I don't think we do that very often, but that's the sort of thing that people come away with. So we could ask something as simple as, what have you learned from other people you've seen about your neck? Let's help you make sense of what you've been told. So overall, what we're really doing when we're organising this information is we are helping to answer my two clinical questions of, why is this person presenting to me in this way at this time, and what can be done to reduce this person's distress and disability. And our goals are to, yes, reduce pain intensity, but really we want to help this person live their life. We don't want people to have to see us all the time. We do want to help reduce their distress, and we do want to improve the quality of life and help people flourish. And my last slide, these are some of the references that I've used. I'll stop now. And yeah, invite you to ask questions.
Thank you very much, Bronnie. It was a great presentation. I would like to ask you, please, to switch the language below, please. So I will, yeah.
I go to English or to?
Yeah, to Spanish.
If I go to Spanish,
yeah.
If I say Spanish, then I'm going to hear Spanish.
No, it's for
go
you.
To English.
So, yeah.
Here we go.
English.
English. Sorry, English.
I only speak Kiwi. It's true.
Oh, Bronnie, sorry, you have to choose English. Sorry.
Yeah.
It's okay? ¿Ya comenzamos? ¿Gus?
Sí, creo que sí. ¿Nos escuchas, Bronnie, en inglés?
I can.
Okay.
I can hear you. I can't hear anybody else, but I can hear you.
Ok. Ya. Entonces, la primera pregunta que rescatamos es, sabemos que la terapia cognitivo-conductual va a tener sus bases en la filosofía estoica. ¿Qué sabes de ello y si tomas aprendizaje desde esa filosofía?
Yes, originally it's about recognizing that it's not life's experiences that matter as much as the view that we take of them. And so cognitive behavioral therapies approaches say that if we can change the way somebody judges or appraises their situation, then this can help them have a different experience. And I think I have moved a little bit away from changing the judgment of the experience to recognizing that we will judge. That's what our minds will do. What we can do is step back and make a choice about how much attention we pay to that judgment. And this is more the acceptance and commitment therapy approach, which says we can change our relationship to our experiences and respond to them differently.
Muchísimas gracias por la respuesta, Bronnie. Segunda pregunta. Si una persona con dolor crónico tiene problemas para poder conciliar el sueño, ¿de qué manera la podríamos abordar teniendo en consideración que esa persona, por ejemplo, trabaje en turnos rotativos, que trabaje durante la mañana, la tarde o en la noche?
Oh, yeah, that is really, really hard. I don't know that I have a very effective strategy because because we are meant to be habit driven, so we would have our sleep at a regular time each day. That's what we do naturally. And so when people do these rotational shifts, it's very difficult. So I'm coming to a point now where I'm beginning to think we can help people think about their sleep pattern, that falling deeply asleep is important, and we will do that biologically when we're hungry for sleep. What bothers people is that they can't fall asleep, or they wake up having slept for a very short time. And so what we could do is help people recognize that even though it might take them a little bit longer to fall asleep, sometimes hours, I've been a bad sleeper in my life, what we can do is help people recognize that when they get distressed about that means that they wake up more. So we can use things like mindfulness. We can say things to ourselves as we're trying to fall asleep that, well, at least I'm resting. At least I'm getting some rest. And we can help people begin to use that sort of process of mindfulness to be aware that their body is resting and their mind is occupied with something else. And that does seem to help. The best treatment for insomnia is cognitive behavioural therapy for insomnia. And the next best treatment is acceptance and commitment therapy for insomnia. And Guy Meadows is the author that I look to for his approach to sleep management.
Muchas gracias por la respuesta, Bronnie. ¿Tenemos tiempo para algunas preguntas más?
Yep.
Sí. Ya, muchas gracias, muchas gracias. Siguiente pregunta. A una persona con obesidad, ¿cómo podríamos modificar tipos de alimentación que no sean favorables para el dolor, pero sin caer en que el paciente se moleste por recomendarle a un nutricionista?
I think it's good to, anybody who's been overweight will know that they're overweight. There's no question. People know that they have gained weight. So we're not telling them anything they don't know. So I like to ask, how do you feel about your weight at the moment? And I'm using motivational interviewing as the approach. And there'll be good things and not so good things about how a person's feeling about their weight. And so if we can help that person suggest some strategies that they've tried for themselves, because most people who have gained weight will have tried 1,000 ways to lose weight. We don't need to shame them. We can just say that we will support them when they're ready to take the next best step. What do they think the next best step might be? So we're not stigmatizing people who are already feeling uncomfortable about their weight and how they feel about themselves. Because I think we forget that when somebody's gained weight, usually they don't feel good about how they look. Our society is not very nice to people who have gained weight. And as somebody who's recently lost a lot of weight, it's very, we know that eating patterns are part of it, but it's more complex than just reducing how much we eat. And so the help from a nutritionist and from somebody who's willing to experiment and play with some different approaches is a really helpful approach. And if the person's ready, if the person's willing, we can offer them that support. But it's absolutely up to the person.
Ok, muy interesante la respuesta. Otra pregunta más, que esta la hace Camila. Camila pregunta, para el manejo de la frustración, historia pasada, entre otros, ¿cómo saber cuál es el tratamiento más apropiado, aceptación, compromiso o la terapia cognitiva conductual?
I think that will depend on your clinical orientation. I will use acceptance and commitment therapy more often than not, because I think that it's, for the people that I work with, it's easier for them to do. They understand it more easily. They don't have to get the pen and paper and write out their thoughts. And it's about moving in the direction of what's important to that person. So I think that is the approach that I would use. When it's things like early childhood trauma or traumatic events that have happened, I think it's not always as important to pull that event out from memory as it is to recognise that that means this person's probably a little bit more fragile, that they're a little bit more sensitive in their nervous system, and bear that in mind, that we need to move gently and slowly and with care to how we approach new situations for the person. So I think that would be I would use ACT, and I would use that I recognise that you're feeling, you've had these traumatic things happen to you, and we know that's probably reset your nervous system so that it's more alert and aggressive. So perhaps we can help you calm that nervous system down a little bit, and we'll move at a slower pace for you. That might be one way of doing it.
Muchas gracias, Bronnie. Muy buena respuesta. Vamos con la última pregunta. Cuando realizas tratamiento a una persona, ¿vas a intervenir uno a uno los distintos aspectos o tratas varios aspectos en conjunto?
I think because people are a network, I start by looking at what is important, what is this person's values, what do they most value, and how can I help them move closer or start moving in the direction of that value. And so it often will be starting off by, what do you think you can do that will help you take the next best step? Sometimes it's starting with creative hopelessness, which is all the efforts that you've tried to fix, control, get rid of this experience haven't worked. And helping that person recognise that all the things that they're trying to do to get rid of this problem is actually getting them more and more stuck. So I might spend some time on that. And then often in a session, I'll move across 2 or 3 or more different areas. But I do that sort of selectively depending on the goal, you know, the direction that we're moving in. What does this person want to prioritise? How can I help them shift a little bit further, a little bit closer to that? So it's very iterative. So we're going over and over and over and coming back to the formulation over and again to change, to revise it over time. not a very straightforward answer.
Bronnie, tenemos la última pregunta, ¿te parece? La última es cortita.
Yeah.
Súper cortita. Una persona te pregunta, ¿qué libro nos recomendarías tú para entender un poco mejor a las personas con dolor crónico?
Difficult question, because I think The Meanings of Pain is a good book for understanding the person, but a textbook that I use is Pain, a textbook for health professionals by Van Griensven, Strong and Unruh, and that was published in 2014 by Guildford Press, I think. It's the textbook that I use in my postgraduate teaching because it has a very person-centered approach. It digs into neurobiology and it digs into neurophysiology, but it also goes beyond that into this person and the sorts of things that are important to the person. And I value that book very, very much.
Muchas gracias, Bronnie. Creo que Nelson quiere darte un pequeño presente.
Sí. Bronnie, bueno, muchísimas gracias una vez más. Estamos muy contentos por la presentación y por poder tenerte acá. Estamos tan lejos, pero a la vez tan cerca. El conocimiento, ¿verdad? Nos une y qué bueno que pueda estar acá.
Yes.
Así que quisiera hacerte entrega virtual
Thank you.
de un certificado. Lo voy a poner acá, voy a compartir pantalla. Ahí está. Quería agradecerte una vez más y entregarte como invitada, como un miembro de nuestra sociedad, un miembro honorario de la Sociedad Chilena de Kinesiología del Dolor. Así que para nosotros sería un honor si tú puedes ser miembro honorario y te vamos a mandar por email.
I would absolutely love that. Thank you so much. You are inspiring, and it's an absolute privilege to be able to present. Thank you so much. Ooh, getting all teary. Oh, thank you.
Dale, Gus, para pasar a lo del...
Bien, ahora vamos a pasar a la parte de la presentación de la sociedad. Así que, Enrique, por favor, tienes tú la pantalla libre para poder compartir.
Perfecto. Un segundito. Acá vamos.
Yes, please.
¿Se ve?
You're doing a fabulous
Ahora sí.
job.
Ya.
Ahora sí.
Bueno, primero que nada, agradecer la audiencia que tuvimos hoy día. Casi 80 entre los dos canales simultáneos, tanto YouTube por Zoom también. Así que ahora, también extendiéndole el agradecimiento a la doctora Bronnie, también vamos a hablar un poquito recordándoles los pasos a seguir para poder ser miembro de la sociedad, porque nos siguen llegando todavía preguntas y personas interesadas. Entonces, bueno, para poder cumplir con los requisitos, que se los vamos a mostrar después, lo primero que hay que hacer es enviar un email a la sociedad, ¿cierto? A nuestro mail oficial. Les va a llegar un formulario online que hay que llenar y mandar los antecedentes que vamos a revisar en unos segundos, esperar la respuesta de la directiva y al analizar nosotros los datos, luego si es positivo les mandamos la información, ustedes pagan la anualidad y luego les mandamos la carta de aceptación de la sociedad. Entonces, los requisitos serían llenar el formulario que acabo de decir, ¿cierto? Junto con la recomendación de 2 socios. Esto por ahora no va a ser necesario, por lo menos durante este año no, porque estamos partiendo, así que descuiden ese aspecto. Y desempeñarse profesionalmente en el ámbito del tratamiento del dolor en cualquiera de sus ramas o áreas, tanto sea traumatología, deporte, terapia manual, oncología, geriatría o cualquier otra afín. Y, bueno, obviamente tener formación demostrable en el ámbito del dolor por medio de cursos, postítulos o posgrados habilitantes. Bueno, algunos interesados nos han preguntado si este tipo de jornadas podían servir, pero la verdad es que por ahora queremos instarlos a poder hacer un curso que puedas certificar y de esa manera nosotros darles el pase a pertenecer a la sociedad. También recordarles que en septiembre, octubre y noviembre tenemos ponentes internacionales de primer nivel, así que vamos a estar siempre en nuestras redes transmitiendo toda la información para que puedan seguir disfrutando de estas grandes ponencias que estamos organizando como sociedad. Y muchas gracias una vez más por la audiencia y atención. Eso.
Bueno, muchas gracias a todos los que estuvieron hoy día presentes en nuestro YouTube y en nuestro Zoom. Les agradecemos a todos y un especial agradecimiento a Natalia, que hizo un excelente trabajo de intérprete hoy día. Es un gran trabajo que no es tan simple y requiere mucho estudio, así que muchas gracias, Natalia, por todo el trabajo que has realizado hoy día traduciendo el kiwi inglés de Bronnie. Que estén todos bien, muchas gracias a todos. Suerte.
It was awesome. Thank you.
Thank you very much, Bronnie. See you.
Thanks, Bronnie. Bye-bye.
Thank you, Bronnie. You're the best.